So just the agenda for what we're talking about: who's a candidate for joint replacement, some examples of some patients, some osteoarthritis facts that will give you some information, some myths that are out there that people are always wondering about, and then the type of implants that we're using, and then I'll open it up to some questions afterwards. So everybody that's here obviously is here because they're interested in joint replacement. They have some arthritis, or they have friends or family members, or they're affected themselves by some form of joint pain. And because the lower extremities take the brunt of all of our hard work and ambulation, hips and knees are most affected, and that's the issue that we're going to really expand on today. And the key thing, the patients that I see every day in my office are people that have to alter their lifestyle, that things are affecting their lifestyle. They can't run after the grandkids, they can't work properly, they can't sleep well, they can't go up and down stairs. So their quality of life is significantly hampered by their arthritis, either in their hip or knee. So these are all questions that everybody sits back and wonders about. How severe is the pain? How often do you feel it? Does it cause you to lose sleep? If you roll over in bed or have to get up at night to go to the bathroom, do you have to limp to the bathroom? Does it interfere with your daily routine? Does it stop you from actually being able to work? And does it stop you from doing the things that you love to do? And because of that, and with the inactivity, have you gained weight because of it? So what would happen if you didn't have those issues? And that's, again, the point that we make in the office. If you had a bad knee or a bad hip, if you didn't have that issue, how would your life be improved? Could you get back to doing the things you like to do the most? And again, how is it going to affect the quality of your life? So here are just some typical examples. This is Lisa, a lady who underwent a knee replacement. And before, she was significantly hampered, couldn't do the things that she wanted to do, couldn't enjoy her lifestyle. She's a dairy farmer, an active tennis player, and again, comment made that her life was passing her by because of the pain. And it not only affected her mobility, but it affected her psychology of how she dealt with things on a daily basis. Another example, a knee replacement gentleman. Basketball referee, tennis coach, wasn't enjoying life, couldn't do the things he wanted to do. Another example, a gentleman who had a hip replacement. And again, all along the same theme. These are people that their lifestyle has been dramatically affected by their arthritis over the course of time. And interestingly enough, in a very quick fashion, with some form of orthopedic intervention, whether it's surgery or not, you can change people's lifestyles dramatically. Again, another example, same thing, basically. Not being able to carry on with normal activities. So here are some facts. So 1 in 5 adults in the U.S. report having been diagnosed with arthritis, and it's probably even a higher level as we get older, of course. 67 million adults will have arthritis by 2030. And its the most common form is osteoarthritis. There are lots of different forms of arthritis, but the one we see most often is osteoarthritis. The one you hear about oftentimes, of course, is rheumatoid arthritis. It's an inflammatory type of problem. Same end result, it destroys the joint, but it's from a different origin. So when you think of arthritis, basically all bones in the joints are covered by a white surface coating. And it's that white surface coating that gets damaged, and it gets damaged in different degrees. And when it ends up where the surface coating is worn off completely, then the joint changes are irreversible. And that's when you hear the term bone-on-bone arthritis. It no longer has that white surface coating that covers over the bone that's very soft, very hard and very smooth. And when you do a joint replacement, you basically remove all that arthritic wear and you put new surface coatings over top. That gets rid of all that arthritic bone-on-bone deformity and gets one smooth surface once again to articulate with another smooth surface. Something that a lot of people are not aware of is there's a real strong correlation with people that have diabetes and also with obesity. So those are things we always are concerned about when we see patients in the office. What other kind of what they call comorbidities or other medical issues are affecting that patient that is associated with the arthritis. So there's all different kinds of treatment options. So the first is, of course, non-pharmacological. You're not even using any drugs. It's modification of activities, physical therapy, assisted devices like a cane or a crutch or a walker, weight loss if at all possible, and things just to try to improve one's lifestyle without any kind of medical treatment. When you talk about using pharmacological agents, you're talking about medications, simple things over the counter like Tylenol, acetaminophen, over the counter Aleve and Advil can be very, very helpful. And then you get into more prescription type medications and then injections into the knee joint and different types of drugs that can help to relieve the pain. And finally, the surgical options, which are variable depending on the degree of arthritis, everything from cleaning the knee joint out or a hip joint out to changing the angles of the joint sometimes can be helpful. And then at the end, of course, a joint replacement to actually get rid of the arthritic wear. So people are always wondering about when's the best time to go ahead and have this thing done. And clearly it's up to a decision between the patient and the physician. It's sort of a team effort to decide what is best and when's the right time frame to be able to do this. Some people put it off as long as they can. Certainly there's no real issue in doing that other than the fact that it changes their lifestyle and they're affected more often than not for a longer period of time. Most people, when they have their joint replacement done, they come in smiling weeks later and they say, if I'd known it was going to be this straightforward and this simple, I would have done this years ago. So here's some of the myths. Number one, you should only consider conservative treatment options. Number two, the total joint won't feel natural. Number three, many of my patients are too young for joint replacement. Number four, my patients should wait as long as possible to get a joint replacement. And number five, all joint replacements are the same. So if you look at all these different myths, people should only consider options. Well, that may be the case, but again, it's a lifestyle decision. And when the patient finally makes the decision, and it's more of the patient's decision, not so much the surgeon's decision, then it's time to go ahead and do it. So when people come in to see me and they say, and we've looked after them for a length of time and done all kinds of treatments, conservative measures like injections or physical therapy, finally they make the decision to come in and say, okay, it's time. I'm tired of living like this. I want to go ahead and have it fixed. They won't feel natural. Well, that's not actually the case. When people are really struggling with their arthritic joints, when you go ahead and put these new joints in, whether hip or knee, it's amazing the technology that's gone in to design these joints, and they do really feel very natural. They may not feel like it's a 19-year-old knee or a 19-year-old hip, but clearly it feels dramatically better than what you had before. It gets rid of the knee pain, and if you do your physical therapy, which is half the battle, then people can actually do extremely well and feel quite normal in their new joint. Now, it used to be a long time ago that we, many years ago, wouldn't even consider doing a joint replacement on somebody who's under the age of 65. But now that's all changed, and it's not so much the age, it's actually the issues with the joint. And it's not unusual to do patients in their 30s, sometimes even their 20s, if they have a joint that's destroyed from some form of trauma or rheumatoid arthritis or even traumatic osteoarthritis where the joint is worn out. It's a lifestyle thing. And now the newer joints and the new materials that they're made out of, they are expected to last for many years. It used to be thought of that the joint replacement would last for 10 years. We have joint replacements that have been lasting for 25, 30 years or even longer. And it certainly is possible to put these in. And now, if you do put one in, and if it does wear out over the course of time, they're all modular, so they can be changed out, so you can remove certain parts and replace them with other parts if one part is worn out. So again, patients should wait as long as possible. Again, we broached that subject already. It's really up to the patient when they decide that enough is enough. And if the orthopedic surgeon states that they qualify from a surgical point of view to have the operation done, then it's a reasonable thing to go ahead and do that. But again, discussion between the patient and the doctor. And all joint replacements are the same. Well, that's not true. Nowadays, the joints that are made fit anybody. Measurements are taken either before the surgery or at the time of surgery to make sure that the implant that puts in fits that patient's knee. A number of years ago, there was a myth out there that women's knees were different from men's knees, and therefore there was one company on the market that actually made a knee that was tailored for women. Well, when they did all the statistics for that, it was all hogwash, to be honest with you. And so all the major orthopedic companies that make knee joints or hip joints, they make them for the right sizes, so they fit really the individual. So let's talk just briefly about hip replacement surgery. So here's the hip anatomy. On the left, that's normal. So that surface coating that covers over the ball is very smooth. In real life, it's actually a very whitish color, and it's very, very smooth. And the surface on the socket side is the same material. It's very smooth, what they call articular cartilage. When you develop arthritis, that's what it looks like on the right-hand side. All that surface coating is worn off, and that's the term bone against bone. And some people, they can actually feel the grinding in their joint, whether it's their hip or their knee, and that's because you've lost that smooth surface covering over the bones that allows one bone to glide on the other. When it's arthritic, it grinds on the other, and that's what causes a lot of the pain and suffering. So when you do a hip replacement, just generally speaking, you go ahead and coat both surfaces of the joint. You put a new socket in place that's made out of metal. It has a plastic liner that goes inside that. Then there's a ball, and in this case, looking at that one, it's a ceramic type ball, and it's attached to a stem that goes down inside the canal of the bone. So basically, the only part that's removed in the operation is this part from here up to here. You remove basically the ball and part of what's called the neck. Everything else still stays the same, but you go ahead and put these new components in that basically removes all the arthritis and gives a very smooth surface to glide on another. Now, there are various approaches, and everybody is on the bandwagon now about this. It's a big marketing thing. There are several different ways of being able to get into the hip joint, whether you go in through the front, the anterior approach, which Dr. Duarte likes. There's an anterolateral approach, the direct lateral approach, posterior approach. All these are various approaches to get into the hip joint, and they're all just access ways of being able to get in. And they're all very good, to be honest with you. And it doesn't really necessarily speak to the approach that you use. It's actually who does the approach. So when you go to all the major meetings, there's always somebody who's going to be up in the podium who says, I think the anterior approach is the best approach. And then you'll get the next speaker that comes up and says, I think the posterior approach is the best approach. And they argue back and forth. And then you get the best guy in the United States to come up to the podium at the very end, and he says, it doesn't really matter. It's the guy who's doing the approach. So you need to make sure whoever does the approach, that they're skilled at it, that they've spent a lot of time learning how to do it, that they have great experience. And all of them, there's a learning curve to them. So it's important that if you see somebody, that they've spent the time to be able to learn how to do it properly and have had good experience and good results with it. And so that's all the information about the approach. There's also information out there, and there's actually St. Pat's Hospital, there's a robot that they have, so-called. It's not truly a robot, it's an arm that's hooked up to a computer that helps to do the operation. But basically, the surgeon is still doing the operation. The robot helps in a way to be able to angle how he does the operation. But it's still left to be decided as to whether or not that's going to be beneficial. And that's part of a marketing scheme as well. When you hear people saying, I have a robot to do my operation, and they televise it, I think that you have to be very careful about that as well. So the approach that I use is the posterior approach, and it depends on the size of the individual. So if somebody is really skinny, you can make it through an incision maybe 4 or 5 inches in length. If you have somebody who's a little bit larger, then you end up extending that incision a little bit longer. It's clear that it's important to be able to gain exposure so you can see what you're doing, and so you can put the implants in properly. So the length of the incision is pretty much determined by the size of the individual. As far as how long people stay in hospital for, it used to be years ago when they started doing joint replacements, people would stay in hospital for 10 days or 2 weeks. Now we have it down to 1 to 2 days, and actually now we can go ahead and do it almost as a day surgery if people are living locally, if they don't have far to travel, if they're healthy and young and have no other medical issues, then it's not all that unusual to actually let people go home later the same day from the operation. And part of the technology that allows us to do this is the approaches we use, the type of incisions we use, and very, very importantly nowadays of all things, there's a new medication that's been on the market for the last 2 years. It's called Exparel. It's a long-acting Novocaine medication. And just like you go to a dentist and he freezes a tooth and he can go ahead and drill and you don't feel anything, we can inject this medication all around the hip or all around the knee, and basically it dulls the pain from the operation dramatically, and it lasts for about 3 days. So people can get up right after the operation, they can walk on their leg, they can bend their hip or knee, and if they're comfortable enough and physical therapy says they're stable and confident enough, then it's feasible for that person, again, young, healthy, living locally, not far away, they can go home the same day, and then home health will start the following day. Nurses will come out to change the dressing, and the physical therapist comes out to the house as well for the next 3 weeks to help them mobilize. So that's still a feasible thing. And the other thing that's important is insurance companies. And that's the crazy thing that drives us crazy on a daily basis, insurance companies. Some insurance companies won't let you do that. For some reason, it's not in their books that you can go home on the same day, and they want you to stay a day or two. And it used to be with Medicare patients that you would have to stay in hospital for 3.54 days for the hospital to qualify for their payment from Medicare to have the operation. So in my discussions with the hospital, I basically said that was hogwash as well, and I'm going to let my patient go home whenever they're safe and confident, whether it's the same day, or whether it's the next day, or at 2 days. So it's a determination made by the physician, the patient, and the physical therapist after the surgery. But people can plan on that. They can come to the office, and if they're comfortable with the concept, and it used to be that most people are just nervous about having this operation and nervous about going home so quickly, really there's no indication to stay in hospital. Hospitals are great places for sick people. Hospitals are not a good place to stay in hospital if you can get out of hospital quickly. The sooner you get out, the safer actually for you to be. So here we go, just expanding a bit more now. When it comes time to putting these hips in, for example, there's all different kinds of implants that can be used, and there's numerous companies. There are probably 6 really good orthopedic companies that have great implants out there. And this is just the company that I use, which is called the DePuy Synthes. It's a Johnson & Johnson company. Dr. Duarte uses a different company that he's comfortable with. They're all excellent. All the implants are great. They do a good job. It's a matter of picking the right implant for that individual, and we do all that very, very carefully. Same thing on the socket side. There's different types of bearings you can have. You can have what's called ceramic on poly, which means that the ceramic ball in here articulates with a plastic polyethylene liner that's inside a metal back cup. You can have metal on plastic. You can have ceramic on ceramic. And there's all different options that we have available. It depends on the individual, depends on their age, depends on their requirements after surgery as to what you pick and choose. Again, a doctor decision. As far as how long do these things last for, well, here's just a simple study, 9 years out, and a 95.8% survivorship. So those are pretty high, records. I mean, people are doing very, very well for a long period of time. Again, this is just more information on the plastic, 98.63% survival. That's at a 5-year study. That's just looking to see how long these things last for. And then they're going on to 10-year studies and 15-year studies. They keep on making these plastics and the metals and the ceramics better and better year after year. Just a busy slide, just talking about wear reduction and how things have improved over the course of time. Again, the biomechanics of these implants are phenomenal. So which bearing is right for you? Again, the doctor makes that decision depending on all these different options. So the benefits of a hip replacement, again, you get rid of all your arthritis, you get pain relief, you get improved mobility, you get an increased range of motion, getting back to the lifestyle that you want. As with anything, you have to be aware there are potential complications. There's always the potential for a dislocation. Very rare, but it can happen. And the physical therapist and the physician will go over the different positions you should avoid after the surgery for a period of time. There's always the potential for nerve injury, implant fracture, infection. All these things are very, very rare, extremely rare. But it's not like going to a dentist and having a tooth pulled. There's a lot more to it than that. So again, it depends on the individual. Is it time to have the operation done? Can you stay with conservative treatment for as long as you can until you're comfortable enough with the concept of having your joint replaced? All these different things are very important. Age and weight, your activity level before the surgery, your general health, the severity and duration of physical impairment, what you can and what you can't do, your attitude towards recovery, and that plays a huge role. So if I see a patient that has a joint replacement, it's a partnership between me and that patient to be able to get them where they need to be. I can do my part, but the patient has to do their part. They have to do their physical therapy. They have to be excited about this. They have to be enthusiastic about it. They want to get better. They want to get back to doing the things they want to do. And that plays a large role in recovery and how fast you recover. It takes time. It doesn't happen even though we get patients out very quickly. It still takes weeks to months to fully recover from these where you're not thinking about that you actually have a new hip or a new knee anymore. It's just part of you. So really quickly going into knee replacements, similar sort of concepts. So again, on the left is a normal knee. The surfaces over the ends of the bone are very smooth. On the right-hand side, just like the hip, the surface coating is worn off and you have bone grinding against bone. And with the implants, similar to a hip replacement, you cover the ends of the bones with implants. And in the knee, there's a metal component that covers over the end of the thigh bone. There's a metal component that covers over the top of the shin bone. And there's a plastic shim that goes between the two. All different kinds of advances again in technology. And one of the knees that I use is called a rotating platform. And that actually the plastic rotates on top of the metal here. So for people that are extremely active, people that want to get as normal a feeling knee as possible, I really like that knee and it works very, very well. If somebody is 85 years of age and they're not as active, they're not playing golf, they're not playing tennis, then sometimes a fixed bearing is acceptable. Again, a decision made more by the doctor than anybody else. There's a new knee that this company came out with. It's called the Attune knee, and we've been using that over the last number of years. And actually, it is a very natural feeling knee. When people have this knee put in, they really feel that it's a normal type knee. That just moves so easily, so smoothly, and it's all very, very polished and very, very smooth. It's actually a very good joint to work with. And so we have people that after these joint replacements that can do this type of thing. Certainly couldn't do it beforehand, but they can get back into a lot of activities afterwards. So again, an innovative knee replacement. The Comet optimized to make your knee feel and move very normally. It all works with the muscles and the tendons and ligaments around the knee joint. Very important, and when these are put in, any knee for that matter, that everything is balanced inside the joint. It's not just a matter of getting rid of the arthritis, you also have to balance the ligaments and balance the stresses through the knee joint so that knee is going to last hopefully for a lifetime. Again, the concept of getting back to what you love doing sooner. And again, this knee I think has done a very good job in that regard. Lots of research, lots of engineering to go ahead and put these things in. And just another testimonial, basically. Another knee that was been around for many years that I've got a great experience with and have put in probably over the last 15 years is the Sigma. Same sort of concept. Again, a metal component that covers over the end of the thigh bone, the metal component on the top of the shin bone, and the plastic that goes between the two. Again, a very good design and has a long track record. And it's stuck. Thank you. Again, these are just different pictures of different types of joints, very similar in nature. And LCS is a very similar type of knee. Again, it has a rotating platform, so this plastic rotates on top of the shin bone here and gives a very natural feel to the knee. Now, if you only have arthritis on one side of the joint, it's certainly possible to go ahead and just replace one side of the joint. And this is what's called a uni-compartment replacement, most often on the inside of the knee. And it can also be put in if you have arthritis underneath the kneecap, you can go ahead and cover the kneecap area up here as well. So the old adage of if it isn't broken, don't fix it. So if you only have arthritis on one side of the joint, it's certainly easy to go ahead and do a partial knee replacement. That's a smaller operation. The recovery is that much faster. And the knee does really feel like your own knee pretty much after the operation. So the latest technology from this company that I use, DePuy, over the last number of years is called TrueMatch. And so the technology is fascinating. So what we do before the patient has surgery is we actually do a CAT scan of the leg. So a CAT scan is a glorified X-ray that takes multiple slices all the way from the hip all the way down to the ankle. And then that information is sent up to the company that makes your knee for you. And they do 3D imaging of the knee based on the CAT scan. They then send that down to me wirelessly on my computer, and I operate on the patient's knee on my computer before they come to surgery. And I position the knee exactly where it needs to go to in that joint to make sure that it's in the perfect position. I send that information back to the company that makes a mold of the patient's knee, And then they send that down for surgery. And when they do the operation, these molds come out. So there's one that goes on the end of the femur bone here. It's pinned in place with these little holes right here. And that slot is where you actually remove the arthritis off the ends of the bone on the femur. And similarly on the shin bone here, that slot is where the saw blade goes in, and you remove the top of the shin bone right there. But it's done in perfect fashion so that everything lines up exactly with that knee. So when you put the knee in, all the decisions have been made basically before the patient even comes to surgery as to where the implant has to go. So the operation to put a knee in nowadays is just a little over an hour. So it doesn't take very long to do the operation, and then the patient with that fancy medication that we inject around the joint can get up and get going on it very quickly. That's part of the reasons why people get going home so fast. They recover faster as well because the knee is put in such efficient manner. So again, those are the little molds that are made. And this mold on this bone basically would fit that individual only. It wouldn't fit anybody else in the world. The whole back of that mold is designed to fit the contour of their own bone. So again, with a knee replacement, you get rid of all the arthritic wear, you get pain relief, improved mobility, increased range of motion. So people that come in that can only bend their knee to maybe a right angle to 90 degrees, after the operation, they're surprised because they can get 120, 125, 130 degrees. They're bending their knee more than they've done in years. So just as with hips, you have to be aware there are potential complications of instability, nerve injury, implant failure, infection, loosening, all extremely rare. Very, very rare for any of those things. So again, just as with the hip, when is it time to do it? And the results following joint replacement depend on all these different factors. Age and weight, your activity level before the surgery, your overall health, how much physical impairment you had before the operation. Again, attitude plays a huge role, perhaps even more so in knees than it is in hips because it requires more physical therapy for knees than it does for hips. So had I known then what I know now, I probably would have done it earlier. That's what, again, the majority of people say. You'll still find some outliers who'll say, boy, it was a struggle, but more and more it's becoming easier to go ahead and do these procedures and faster for people to recover. Thank you. Now for fun, I want to show you something that I thought you might find really interesting here. So I'm involved with a company actually that my son's involved with out in California, and it's called BioFlight. Now this has nothing to do with orthopedics specifically. Can we down the lights a bit more, do you think, so we can see this a bit better, do you think? So I did an MRI scan of my knee, and this company, which actually does a lot of work with Hollywood movies, is getting into biomedical information. And they're able to take my knee off of an MRI scan, and they're able to go ahead and get all the information off my knee to be able to do this. And so in the future, there are these special goggles called Oculus goggles, or Samsung has them now, and Microsoft has HoloLens. You'll be able to put these goggles on, you'll actually be able to see inside the person's knee. And you'll be able to walk in, and in the future, you'll be able to actually be able to do surgery. Now that's way down the road, but people will actually be able to do an operation by being able to put these goggles on and be able to actually see inside the joint as opposed to what you can normally see now. And here again, that's my knee. That's the vascular pattern. It's hard to see because it's so bright. But if you put these goggles on, it's actually, you can actually literally look right inside the joint. You can walk around inside the joint and see all kinds of things. That's just literally just the vascular pattern on my knee to begin with.
We're just going to get you this lip on.
And so my son was on the right and his friend on the left came to my office, and the KPLC came and did this little thing, and that's me with the goggles on, and that's my knee. You can look inside. Look at this three-dimensionally, be able to walk into the knee, look around inside the joint, upside down, and be able to diagnose things much more accurately. It's pretty phenomenal.
Rick Shorten, Jim Reeves, and their team with BioFlight VR have spent years making movies and TV shows.
And we have muscle, and we have bone, and we have vascular and skin.
With a vast medical image library, they wanted to find a way to tap into a virtual reality platform for the healthcare industry.
We had kind of approached it with the CSI going inside the body, and he was a little skeptical because it's easy to put up a video where people are watching on television versus a doctor who needs specific data on to do their jobs.
So the BioFlight VR team collaborated with Dr. Cohen on how a tool like this could change the landscape of surgeries.
We've beta tested this with cardiologists, with general surgeons, neurosurgeons, so there's opportunities for all these different specialties, but also family practice.
When you put on the Oculus goggles, you're in a flight simulator of sorts for doctors.
The device tracks your upper body, so as you move, the device changes your field of view. It's full 360, so when you're inside the rift, everywhere you look around, it replaces the entire environment that you're in.
It's almost like I'm living inside the joint. It's an entirely different perspective, never seen before.
BioFlight uses patient-specific CT and MRI data in true 3D. 360 Capture Live offers virtual presence opportunities for remote training. The next goal is to offer the sense of touch.
Down the line, we're hoping that when the haptic feedback, the idea of actually reaching out and touching something and feeling it push back, when that technology catches up, we have a lot of ideas about virtual surgeries, replacing cadaveric training and wet labs.
It's going to change dramatically what we are able to do from a diagnostic point of view, as well as what we're able to do from a treatment point of view for patients.
At your service with HealthCast, Brittany Glazer, KPLC 7 News.
Interesting. I just thought you'd get a kick out of that. That's kind of fun. Okay. So any brief questions for me before I turn it over to Dr. Duarte and let him expand on what he has to talk about?
All right, I wanted to expand upon something before I forget. I think it was, I forget who's, the 13 years ago, total knees, bilateral. Okay. It's very important, and I tell this to all my patients, even if you're pain-free, rocking and rolling, playing tennis, doing whatever, I think a minimum of every 2 to 3 years you need to get an x-ray, because there's things that can happen early on that we can recognize, and you could get a very simple surgery to fix it, whereas if you miss it, it's going to be this very complex surgery. So, I mean, I hope it's something, and I think it's the job of the orthopedic surgeon to make sure the patient knows that, you know, that it's not just a wham bam, you got a new knee, have a nice life. It's a relationship that goes on. So let's get started. There's a lot of things in my talk that were already covered, and so we're not gonna beat it to death. There are a lot of things. There's a lot of parts of a joint, and so when anything goes wrong with any of those parts, you can have pain. So hip pain alone doesn't necessarily mean you have arthritis. There's bursitis. There's labral tears. There's a lot of other things that can cause pain. And so we already discussed loss of the cartilage. That's essentially what arthritis is. For that reason, that's why no one ever needs a knee replacement. All you are is you're losing the padding. That just means that when you put weight on it and push the bone against the other bone, you have a lot of pain. But no one ever died from hip pain. No one ever died from knee pain. So that's why Dr. Cohen and I will tell a patient, you're a candidate, you're going to know when you're ready. Because the point of this surgery and the point of everything we do with arthritis is to make the pain go away. And so that's why when it gets to a point that the injections, all the things aren't working, then that's the only time we talk about doing a surgery. So unfortunately, there's no way to prevent arthritis, I guess, unless you never take a step. But there are some important risk factors. The main one is obesity. So 6 times somebody's weight is the contact forces that you're going to have in your joints. And so if someone were to lose 100 pounds, you know, if they're that big, that's 600 pounds less on your knee joint. And it used to be thought that that was the reason why with obesity, a lot more obese people would have arthritis. But if you look at it, there's also a very high incidence of hand arthritis. And so unless they're all a bunch of carnies, you know, walking on their hands, you would think, okay, well then maybe there's more to it than just more weight pushing the bone against the bone, and there is, in fact. So it turns out that fat cells actually make these signaling proteins that actually cascade the inflammation pattern and actually make arthritis worse. So if there's anything I were to tell people to try to help with arthritis, it would be that, you know, weight loss does help. And we went through all of this. I think the biggest gun we have, aside from activity modification and the weight loss, is the injections that we do. Now, there's some people you inject them, they're pain-free for a year. There's others that are pain-free for a few months. Every now and again, you have people that it doesn't help, and that's when it's time to talk about doing something more. We covered this one. And again, you know, we're never going to tell you need a knee replacement. You only do it when you feel functionally disabled, when you can't take it anymore, and people know when they're ready. And again, age isn't a big factor. I think one reason why it used to be a factor is the technology that we used to have wasn't that great, and so we were worried about the longevity of the components. But now, with the new kind of plastic, they last a lot longer. But more importantly, if they do fail, the technology we have now is way better than what we used to have. And so, I mean, I've gotten people that are 3, 4, 5 revisions in, and there's still something we can do, and we can still fix it. And it's only getting better, and I think that's one of the reasons why we're being more tolerant of addressing younger patients. We covered some of these. And again, different approaches. I've done them all. My favorite are posterior and the direct anterior, depending on what I'm doing. The posterior approach, you pretty much, in order to get into the hip joint, you have to get the superficial structures out of your way. And so with the posterior approach, coming from the side, you have 5 muscles that you have to cut in order to get in there. Now, yes, they grow back, but that's one of the reasons why the posterior approach is a little bit more unstable than the anterior approach. Although remember, all that matters is the way the implants are put in. And you can go in and do very little muscle trauma, and if the implants are put in crooked or rotated, the person's not going to be very happy with you. Lateral approach, they all have their pros and cons. This one's more stable, but you end up cutting into your abductor muscles, and so people tend to have more of a limp because your abductor muscles are the ones that hold your pelvis upright when you lift one foot off the ground. Direct anterior, this one's my favorite, especially in primary situations on a native hip. Here's the claimed benefits of the approach. You know, less trauma, less muscles getting cut, faster recovery, therefore less pain, less restrictions. You don't have to sleep with a pillow between your legs, decreased risk of dislocation. You can also take x-ray during the surgery as you go, so you know that you're more happy, more confident with the way everything's going in. The reasons I like it, I do believe in this one, improved early function. I will tell you that there is not a study you're going to find showing that at 3 months and beyond, there's any difference between any kind of approach, except maybe the lateral. Maybe they might have a limp. But between direct anterior and posterior, if you do it right, at 3 months, everyone's going to be doing fantastic. They're all going to be very happy. But early on, it is nice to not have to worry about what position your hip is in, and I do notice that there is improved strength early on. Honestly, I don't even think there's much of a difference with pain. I feel like with the Exparel and the technology we have nowadays, people are pretty comfortable after a total hip. This one's another big one though, because of the stability of the approach. You oftentimes have to make up one hip a little bit longer, and makes the extremity longer to make it stable. With the anterior approach, it's inherently stable. You have all the muscles that are never detached, and for that reason, you can just dial out the length to match the other side, not to make them stable. And that's another reason why I like it. And also anesthesiologists like it because the patient's on their back and it's easier to manage the airway if they're under general anesthesia. Another reason I like it is where the location of the incision is. It's about a 3-inch incision on the front of your thigh, and I think it's a little bit easier to take care of in that location as opposed to back here. And also in hip fracture situations where I use this approach, if you have an elderly patient that falls, breaks their hip, sometimes they get a little confused while in the hospital, and it's nice to have an incision that's kind of away from any areas that can get more prone to being soiled. Also, when you're doing a 3-inch incision, you have more time to spend on doing more of a plastic surgery closure, so the scars end up coming out pretty nice too. For knee replacements, there's a muscle sparing option as well. Typically when you do a knee replacement, and this is most surgeons, I'd say at least 90%, you start your incision going up the side of the patellar tendon, around the kneecap, and then you go up into the quad muscle. You got to get all that stuff out of your way in order to put the knee in. There's a technique where I come up the side and go around the muscle, move the muscle out of the way, and I definitely find that there's improved quad strength, almost like they didn't have surgery. Pain difference, not too different, but as far as strength and how well they're getting around after the surgery, this is definitely a good approach. I will tell you that you can't do this one on everybody. If someone has really massive quadriceps muscle or just a giant leg, you're going to end up doing more damage stretching it than you would just cutting it. So you're better off just doing the cut. But there are a lot of people that are candidates for this approach. Arthritis is not just in the hip or the knee. If it's in another joint, there's things that can be done, and we have partners that do it, but Dr. Cohen and I will refer you accordingly. Some other technologies, we touched upon the partials, great surgery. It's essentially a same-day surgery and pretty much no physical therapy needed for it. Another thing that I've been doing, Dr. Cassio is also doing this one, and I'm not sure if you've tried the subchondroplasty. It's thought that the pain from arthritis comes from the bone immediately under the cartilage that's getting worn away, and it's thought that people get these insufficiency fractures that you can sometimes see. So someone with bone-on-bone arthritis, you get an MRI and you see this edema, this kind of a bone bruise underneath the cartilage, and what we do is we go in during the time of a knee scope and we inject that area with a bone marrow substitute, and it actually seems to work pretty well. I will say at this point with the ones I've done, I call it a Hail Mary. I tell the patient, look, if I have someone really young, let's give it a try. You know, worst case scenario, it just won't work too well. Best case scenario, you know, it may help with your pain, and I do notice that about 60% of patients notice a marked improvement. I had one guy, completely bone on bone. I recommended a total knee replacement. He wanted to try this, and 4 days after surgery, he started running 4 miles a day. And not everyone does that, but this guy did.
Can you do that on the hip joint?
What's that?
Can you insert that in that hip joint?
You can, if you have it. I've tried it. Depending on where it is. If in certain spots, if you do that procedure, you're going to make you more prone to a fracture. So it depends on where it is. And then we talked about these blocks. I use a different company, and theirs are MRI based, but it's still a great technology. And essentially, this is computer navigation before you go into surgery. The alignment, the rotation, the human error of positioning the component is taken out of the equation. Also important is before we had this technology, the way we found out what angle we need to make that cut, what rotation we needed to do, is we would put a rod up your femur, and this precludes that. So now, without having to do that, you don't have all the blood loss, you have less pain, and this really is a game changer. We talked about the Exparel. And I just want to talk a little bit about some things that I've been doing since I've gotten into town here. So a joint can fail with, you can fracture around your component, the components can wear out, they can get infected, the ligaments around them can get stretched out and they can become unstable, they could be put in poorly. And you have some that have even been done several times and don't seem to be doing any better. I call them, some of these are some train wrecks. And so here's a guy, he actually had he had this going on in both of his knees. He hadn't walked for about a year because of this knee, and this knee is infected, and it also is very loose, and the components are loose too. And the typical treatment for this is you take the knee replacement out, you put an antibiotic spacer in, you keep them off it for 6 weeks, 8 weeks, 6 weeks of IV antibiotics, and then you do another surgery and you put your final components back in. 95% of the time, and I do just one surgery, take everything out, clean it out really well. These little spheres here are time-release antibiotic beads. I put them down the tibial shaft, up the femoral shaft, and then clean the knee out really, really well, and then put their final implant in one stage. And so 6 weeks IV antibiotics, this guy's good to go. And he's walking like he did after his first knee replacement on post-op day 1. Here's a guy, a little worse off. He had, I think, about 8 to 10 hip replacements done in Houston, and then he let Baton Rouge get a couple tries on him. And he actually had an implant when I first met him, and he had been draining pus for about 2 years from his femur. So step 1, his was so bad, I usually do spacers. I took everything out. Took everything out, treated him with antibiotics, got the infection under control. Then I made this spacer for him a couple weeks later, and this is a hip replacement that is cemented, and then essentially a cobalt chromium piece of metal that goes all the way down and anchors right above his knee joint. I took all this bone, had chronic osteomyelitis infection in the bone. I just took that bone out. And then after I got the infection under control, this is a suboptimal fixation here because you're trying to put a inverted triangle into a triangle and it just doesn't grab too well, but this was just a means of getting the infection under control. I didn't want to spread it to his knee just in case we were unsuccessful. But once we got the infection under control, then I built him entire femur. So he has no femur. This is just metal that connects the hip replacement to a knee replacement. And we got him walking and he's doing great. This guy, the surgery wasn't done here. He had a femoral neck fracture, a fracture right under the ball. He had it treated with this device. And initially he did well, but he went on to develop avascular necrosis, which the blood supply to the ball gets cut off. So the ball collapsed and he ended up with hardware in the joint. Insult to injury, he also ended up getting infected. So this was also infected. Removed the construct and ended up giving him a hip replacement, and he's doing fantastic. This is not your straightforward knee. I don't remember if you all remember what the normal knee looks like, but his is very angulated. He had a gunshot wound to the inside part of his tibia about 10 years ago. That got infected. They took all the hardware out, and he's been walking with this angle for, well, not really walking, but hobbling around. And the treatment for this is there's a little piece of bone, a little fragment of bone right here that I kind of, using a burr, I made it into a puzzle piece and puzzle pieced it back into the knee and then plated that on there with screws and then put a brand new tibial stem in and just a primary component for the femur. And he actually ends up, what he has in there is the same implant you would give somebody that had run-of-the-mill arthritis. So even though he was younger and he had this horrible deformity, he ended up getting a basic total knee that would have the same longevity as all the ones that we're using today. This was done nearby, and there's two things wrong here. Number one, this cup is pointing in the wrong direction, and it's inside the pelvis. And number two, this is a recalled implant that in and of itself is not a bad thing, but the reason why this implant does poorly is when you have a really long neck, which they put on there to try to make it more stable, as you walk and this head wants to toggle up and down, it causes friction right here that releases metal particles. And so when I went into this hip, it was completely black. I resected all of the inner lining of the capsule out. I thought I was going to end up needing this kind of construct, which we call a cage, which is a cup that has these plates coming off the side. And it just makes it for stronger fixation, but I was actually able to get a run-of-the-mill cup with a couple screws in there. I put a whole bunch of bone graft behind the cup, and she's fully weight-bearing, doing fine. This one is a real mess. This is a typical antibiotic spacer. He had a hip infection and also had arthritis on the other side. I'm sorry, avascular necrosis. He's about 35 years old. When I met him, he hadn't walked for 3 years. On this side, his antibiotic spacer fractured, and the surgeon recognized it, and instead of dealing with it, decided to go ahead and put another total hip on the other side. In the time being, well, this cup is I would say maybe 70 degrees up where it should be about 40. So the cup itself wasn't put in right. It was put in so poorly that another orthopedic surgeon actually thought it was loose and just rocked loose, but it wasn't loose. That's the way it was put in. And so I had to stage him. There's a lot of work here to be done. Step one is I addressed the known infected side. And so we took the spacer out. I put in a less barbaric spacer. These are the way I do my spacers, which is a cemented cup, a cemented femoral stem. There's antibiotics inside of the cement. You can see the time-release antibiotic beads that I put in there. And we treated him 6 weeks IV antibiotics and then put in a standard total hip with a long stem that grabs all the good bone down here. And this is press fit, meaning no cement. It's just gripped to the bone because we prepare a hemisphere that's slightly smaller than the one we put in. And this grips the bone here. And we got that side under control. Then we turned our attention to this side. And then and this side also turned out to be infected. And I did a single stage revision on that side, and then we got him matching. And he walked into my office about 6 weeks ago, brought tears to my eyes. First time he had walked in 3 years, unassisted, no cane, no walker. Another situation, so this patient, they've had this knee replacement about 20, 30 years. And one of the reasons why we like to take these x-rays is as this plastic wears out, the plastic particles go throughout the knee and they start making your bone weaker. And we call that osteolysis. And you can see it on x-ray. You can see the bone getting weak. And so when we see that, we would tell you, hey, we need to get in there, take that plastic out, put a fresh piece of plastic in, and your body actually reverses it. You don't have to do bone graft or do anything. Well, this patient never saw the orthopedic surgeon, had a fall, and fractured through that weak, soft bone. And a CT scan of this actually showed that there were several fragments that went all the way down into the implant. And so to fix this, you need a long plate going all the way down with a bunch of screws. Can't put any weight on it for 6 to 12 weeks. And then there's a chance that even after 6 to 12 weeks and not even able to put weight on it, it won't heal. So what we did just to avoid all that is I just rebuilt the femur from the area that it was fractured into a new knee replacement, and we had her walking fully weight-bearing day of surgery. And that is it. So anyway, anything that can happen to a hip or knee here, we can take care of. Anything that can happen, we can fix it. Is the point of my story. Questions, anybody?